first up. Hi, today we're going to talk about the brachial plexus. You can follow along with your lecture notes from pages 73 through 74 in your lab manuals, pages 55 and 56 when we talk about the vessels. And also make sure you pull out the handout, the brachial plexus handout that I sent to you via email. So the brachial plexus is a network of nerves that supplies our upper limbs. It's formed by the anterior rami of spinal nerves from C5 through T1. So let's have a little review of our spinal anatomy. Here's our spinal cord. In the blue, we have the posterior nerve roots or the dorsal nerve roots bringing sense, and their sensory nerves bringing sensory information to the central nervous system. In the red, we have the anterior nerve roots or the ventral nerve roots bringing motor information outside the central nervous system. They combine at the region of the spinal nerves, and the spinal nerves are a mixed nerve made up of sensory and motor fibers. Then it divides into a posterior ramus here and an anterior ramus. And the anterior ramus is what makes up our brachial plexus, and it's an extension of the cervical nerve roots from C5 through T1. So the brachial plexus is subdivided into subunits. Here, the roots, the brachial plexus is made up of the anterior rami of the spinal nerves from C5 through T1. These roots unite to form trunks. So the upper trunk is made up of cervical nerve roots C5 and 6. The middle trunk is C7, and the inferior trunk is from C8 and T1. This is further divided into divisions. The anterior division is going to supply the muscles in the anterior compartment of our upper limb. The posterior division is going to supply the muscles to the posterior compartment of our upper limb. The anterior division is going to further divide it into cords, the medial and the lateral cord, and the posterior division is going to go into the posterior cords. These cords are going to further break up into the terminal branches. The medial and lateral cord will divide to the median, the ulnar, and the musculocutaneous nerve. The posterior cord is going to divide it into the axillary and the radial nerve. So here's I know this image is from your textbook, and it gives you a mnemonic to memorize the subunits of the brachial plexus. Know the order for your exam and for your lecture exam and for your practical. We have the roots, trunks, divisions, cords, and branches. Risk takers don't cautiously behave. Mine from more than 30 years ago is Robert Taylor drinks cold beer. So the roots are the anterior rami from C5 through T1. You can see here clearly how the superior trunk is made up of the nerve roots of C5 and C6. The middle trunk is from C7, and the inferior trunk is from C8 and T1. This is going to divide into the anterior and posterior divisions. The posterior division is going to go into the posterior cord. The anterior division is going to separate into the lateral cord and the medial cord. The cords are going to divide into the terminal branches. So clearly you can see the lateral cord is going to supply the musculocutaneous nerve and one half of the median nerve. The medial cord is going to go into the ulnar nerve and the median nerve. So we're talking about the upper limb. You can see here the image of our upper extremity, and we always refer to anatomical position. So this model is an anatomical position. The palm of his hand is facing anteriorly. So here we could see the humerus and the radius, which is lateral, and the ulna, that is medial. We're talking about brachium. It's this region in here along the humerus, and the antebrachium is a region where we have the radius and the ulna. The anterior compartment is the muscles anterior to the humerus, and also in the antebrachium, and the posterior compartment are the muscles behind the humerus and posterior to this region in the antebrachium. The lateral cord is going to supply the musculocutaneous nerve, and the musculocutaneous nerve supplies the muscles in this anterior compartment of the antebrachium. And part of the median nerve is off the lateral cord. The median nerve is going to go and supply most of the muscles. We call this the flexor compartment of the antebrachium. There's a couple of exceptions, which we'll talk about in a minute. And this median nerve is also supplied not only by the lateral cord, and also by the median cord. The ulnar nerve is going to go into this flexor compartment, and it's going to innervate the two exceptions in that flexor compartment, most of the hand muscles. The posterior cord is going to divide into the axillary nerve. The axillary nerve travels around the head of the humerus and is going to innervate a couple of muscles in this region. And the radial nerve is going to supply the muscles in the posterior compartments of the brachium and the antebrachium. So let's continue with this. We'll go into detail over the 5 major terminal branches off of the 3 cords. Off of the posterior cord, we have the radial nerve and the axillary. Off of the lateral and the medial cord, we have the median, musculocutaneous, and the ulnar nerve. So let's start with the axillary nerve. The axillary nerve supplies 2 muscles, the deltoid muscle and the teres minor. Here's the deltoid muscle, and this one right in here is the teres minor. The deltoid muscle has 3 origins and insertion into the humerus. So the actions of the deltoid are going to be shoulder, let's see if this works, abduction, so it's bringing the arm all the way up like that. Medial rotation would be bringing this forward, and extension, bringing this backwards. The teres minor muscle is one of the 4 rotator cuff muscles. It's actually the T in the sits mnemonic. Remember that? T, S. So it's this muscle right here, the teres minor. And the teres minor is responsible for lateral rotation and shoulder adduction, so bringing the shoulder inward towards the center of the midline. Let me go back to this again. So the medial nerve is off the medial and lateral cord, and that's going to supply this flexor compartment in the antebrachium, in the anterior compartment of the antebrachium. So an easy way to remember this is that it's going to supply all the muscles here, and just memorize the exceptions, which are innervated by the ulnar nerve. That includes the flexor carpi ulnaris and 1/2 of the flexor digitorum profundus. A condition associated with an injury to the median nerve is called carpal tunnel syndrome. The median nerve passes underneath this transverse carpal ligament, and it's going to supply the muscles in this thenar eminence. When we're looking at the palm, the region below the thumb is called the thenar eminence, and the region right below the 5th digit is called the hypothenar eminence. So with carpal tunnel syndrome, One of the symptoms is numbness and tingling along the first, second, and third phalanges. Sometimes there could be muscle atrophy or wasting along the thenar region. This syndrome is an overuse syndrome from excessive and repetitive wrist flexion and extension movements. Could be caused by a simple activity as the use of the computer. The median nerve is going to supply these muscles, these anterior flexor compartment in your antebrachium. We talked about these when we studied the muscles. I'll do a brief review on them. We had 3 layers in these antebrachium flexor compartment. The top layer would be the pronator teres. They're all going to originate along the medial epicondyle. Pronator teres. Then secondly would be the flexor carpi radialis, and the one in the middle, which is the palmaris longus. The palmaris longus goes over this flexor retinaculum. And then the exception, which is on this layer, is the flexor carpi ulnaris, but that is ulnar nerve. If we could tear that layer off, this layer would be the flexor digitorum superficialis, and this muscle inserts into the proximal phalanges of numbers 2 through 5. We call that bye-bye muscle because when it flexes the phalanges, it allows us to say bye. The next layer down would be the flexor digitorum profundus. It's underneath the superficialis, and this one inserts in the distal phalanges, and that allows us to make a fist or curl our phalanges up in order to make a fist. This is the other exception that we talked about. The medial half of the flexor digitorum profundus is ulnar nerve. The lateral half is median nerve. The other muscles in this region that are innervated by the median nerve will include the pronator quadratus, which pronates our antebrachium. It's underneath this one in this region. Anytime you see pollicis, it's associated with the thumb. So there's a flexor pollicis brevis and an adductor pollicis brevis and opponens pollicis, all associated with the thumb movements. And also lumbricals 1 and 2, which are muscles around the phalanges, all innervated by the median nerve. The musculocutaneous nerves innervates 3 muscles in this anterior compartment of our brachium. The median nerve will immediately go into the coracobrachialis. It's often very easily identified, especially if you're looking at models or images of the cadavers. The next muscle is the biceps brachii, and then underneath the biceps brachii will be the brachialis. The coracobrachialis is responsible for arm adduction and flexion. The biceps brachii is responsible for elbow flexion and supination, and then the brachialis is primarily elbow flexion. The sensory fields, or the cutaneous sensory fields of the musculocutaneous nerve, is the lateral arm in this region in green. The radial nerve off the posterior cord is going to supply the muscles in the posterior brachium and also the posterior antebrachium. In this posterior brachium, the main one we have is the triceps brachii muscle, and that primarily extends our forearm. We can easily recognize it on the models because it's one muscle that inserts on the olecranon process of your ulna. There's another muscle here. It's called the inconius, also small underneath that. A condition associated with radial nerve injury is called wrist drop. We'll get into this in a minute. The radial nerve also supplies the posterior compartment of the antebrachium. And there are several muscles in this region. We call most of it the extensor compartment. We talked about these muscles when we studied the upper limb muscle chapter. The first one in this group was the brachioradialis, responsible for elbow flexion, supination, and pronation. Then we get into the extensor group. So we talked about how it's easiest to memorize them in order. The first one would be the extensor carpi radialis longus, and there's an extensor carpi radialis brevis. These two are responsible for wrist extension, but because they're on the radial side, they're also going to pull the wrist up, called abduction. The extensor carpi ulnaris is on the ulnar side, and this one is going to extend the wrist, but also adduct because it's in the middle, medially pulling it closer to the midline. The extensor digitorum goes to the distal phalanges, and upon contraction, it's going to facilitate extension of the phalanges 2 through 5. Extensor digiti minimi. Remember, digiti minimi means the fifth phalange or little pinky. It's going to extend that. Extensor indices is goes to the index finger or number 2 and extends that. Then we have 3 extensors, 2 extensors associated with the thumb. We have the extensor pollicis longus, and then medially would be extensor pollicis brevis, and then even most medially would be the adductor pollicis longus. Underneath all these here, we have a muscle called the supinator muscle, which supinates our antebrachium. So all of these are associated with the radial nerve. Sensory changes to the radial, are located here in red, which would be the posterior brachium and the posterior antebrachium in hand. The ulnar nerve is off the medial cord, and it's going to pass very superficially in a little indentation between the medial epicondyle and the olecranon of the ulna. And this is what we call the funny bone. Sometimes if you accidentally hit your elbow in this region, it'll shoot like an electrical sensation into your 4th and 5th phalanges, sometimes called the funny bone. This nerve is going to go medially and is going to innervate those 2 exceptions, the flexor carpi ulnaris on that superficial layer, and then the medial half of the deep muscle called the flexor digitorum profundus. An injury of this sometimes, and I'm sorry, this is incorrect, would cause claw hand. So not only will it cause sensory changes or numbness and tingling into the 4th and 5th phalange, but it could also cause these fingers to curl up, causing a condition we call claw hand. We talked about how this is the thenar eminence innervated by the median nerve. This is the hypothenar eminence innervated by the ulnar nerve. So the ulnar nerve is going to supply those 2 muscles in this region, which includes the flexor carpi ulnaris and 1/2 of the flexor digitorum profundus. It's going to innervate most of the hand muscles. In the hand, it's going to, they're listed here, the flexor digiti minimi, the adductor digiti minimi, and the opponens digiti minimi, all surrounding the 5th phalange. It innervates the web or the adductor pollicis, the webbing between the thumb and the index fingers. The lumbricals and interossi are muscles connected to the phalanges, and it's connected to the 4th and 5th phalange, and also the palmaris brevis, also located below the 5th phalange. So let's talk about the relationship between the artery and the brachial plexus. The axillary artery is this one in red. We could see how it goes through the terminal branches of our brachial plexus. If you pull out the sheet I sent you, I would like you to highlight the M where we see the terminal branches of the brachial plexus. And as you can see, the axillary artery here, the lateral cord is lateral to the axillary artery, the medial cord is medial to the artery, and then laterally and anteriorly we could see the musculocutaneous nerve and the median nerve. Medially we see the ulnar nerve. Behind the axillary artery, we could see the posterior cord, the radial nerve, and axillary nerve off of the posterior region of the axillary artery. So often we color the M to get like a point of reference when studying the brachial plexus. And seeing this, we know that the the lateral cord gives rise to this musculocutaneous nerve, and this nerve is going to immediately pierce the coracobrachialis muscle. The long part of the M is going to be the median nerve, and then the most medial part, the medial branch of the M, is the ulnar nerve. What goes through this is the axillary artery, and then posterior to this, we're going to see the radial nerve and the axillary nerve. So you can see here the pectoralis minor muscle crosses over in front. If we could cut through this off of its insertion, roll it up, then we would see the axillary artery. The axillary artery is an extension of this subscapular artery, which we'll go over when we study the vessels in a little while. So it's important to look for that M when we're getting our bearings, when we're trying to figure out the nerves in this axillary region where we see the brachial plexus. Again, the lateral branch of the M is the musculocutaneous nerve going into that coracobrachialis. The middle part of the M is the median, and then the medial part of the M is the ulnar nerve. Here you can see it on a cadaver. We clearly could see the roots from C5 through T1, the trunks, the superior, middle, and inferior, the divisions, and then clearly we could see the cords. Here's the lateral cord going into the musculocutaneous and the median. Here's the medial cord giving rise to the median and the ulna. Here's our axillary artery through that. If we could draw the M here, which I'll try to do it for you here in color, would be this, this, and that. Okay. And here's the axillary artery. Up in here would be the axillary artery, and then here is the posterior cord giving rise to the radial nerve going into the posterior compartment, and the axillary nerve traveling around the head of the humerus. This is the subscapular artery, which we'll talk about in a minute. So let's talk about nerve injuries. Again, wrist drop. Try to memorize it this way, knowing what the condition is and what nerves are associated with these conditions. So wrist drop is associated with radial nerve. Numbness and tingling into the first, second, and third phalanges is associated, and wasting of the thenar muscles. Here's the term thenar, and then here is the hypothenar. I know those are in your manuals, So numbness and tingling into these and wasting of these muscles is connected to the median nerve or carpal tunnel syndrome. And then the claw hand, wasting of these hypothenar muscles is connected to the ulnar nerve. Other injuries associated with the brachial plexus is divided into upper plexus injury. Another condition associated with this is Erb's palsy, where we forcefully increase the angle between the neck and the shoulder, whether it be during childbirth, if the baby's neck is pulled excessively, or a fall in this position, we can injure that upper plexus region between C5 and C6 spinal nerves. So the symptoms of this is what we call waiter's tip deformity, primarily because the shoulder is adducted, medially rotated. There's flexion of the wrist and loss of sensation along the lateral arm, and we call that the waiter's tip posture associated with an upper plexus injury. A lower plexus injury is a forced pull along the C8 T1 nerve roots. Sometimes occurs if you accidentally fall and you forcibly abduct and pull the shoulder. It can cause a condition associated with ulnar nerve injury that includes the claw hand and sensory loss along the medial arm and forearm. That's called Klumpy's palsy. Axillary nerve injury, we talked about how the humerus, the anatomy of the humerus, we have the head of the humerus, the surgical neck, the anatomical neck, and then the surgical neck is located here. Remember, we called it the surgical neck because it's a region that often, if it's fractured, it needs surgery. The axillary nerve travels in this region. So if there's a surgical neck fracture or shoulder dislocation, it can cause an injury to this axillary nerve. And we talked about how the axillary nerve innervates the deltoid muscle and the teres minor. So a sign of this could be atrophy in those two muscles, and also lack or weakness in shoulder abduction, or trying to lift the shoulder away from the midline could be a sign of axillary nerve injury. So this is the handout I sent you. As you notice on mine, I highlighted the M in yellow, so I'd recommend you do that. I like this handout because it goes over, it's kind of a quick reference sheet when you're studying for your lecture exam. Along the bottom here, make sure you understand the order. Robert Taylor drinks cold beer. Along the right side here, we have the anterior rami of cervical nerve roots of C5 to T1. Then I like this because it also shows you the nerves associated with the brachial plexus. So off of the nerve roots of C5 and C7, you could see two nerves. The dorsal scapular nerve innervates the rhomboids and the levator scapula. We talked about the long thoracic nerve. Make sure you know that one for your exam. This one is associated with innervating the serratus anterior muscle, and a condition with that was winging of the scapula. Remember the image of somebody doing a push-up against the wall, and that scapula would stick out. Then we further divide it into trunks. In the trunks, we have a nerve here, the suprascapular nerve. Okay, make sure you know that. It innervates two of the four rotator cuff, the supraspinatus and the infraspinatus are off the superior trunk. Then we get to the divisions. There is no nerves in the divisions. And then we have the cord. So there's several nerves that come off the cords. The lateral cord gives rise to the lateral pectoral. The medial cord gives rise to several cutaneous nerves, but make sure we focus on the posterior cord. So the one we talked about in the past was that the thoracodorsal nerve is going to innervate the latissimus dorsi. These two, upper and lower scapular, associated with the subscapularis and the teres minor, which are part of the rotator cuff. Know the radial nerve and the axillary nerve. The axillary nerve innervates the deltoid and teres minor. An injury to this and associated with the surgical neck of the humerus can cause lack or weakness in shoulder abduction. The radial nerve innervates all those brachium and antebrachium posterior compartment muscles. Condition associated with that was wrist drop. So off the lateral cord, we've got the musculocutaneous nerve, innervates those three muscles, the coracobrachialis, the biceps brachii, and the brachialis. The median nerve is associated with the muscles in that flexor compartment of the antebrachium. Know the exceptions that are innervated by the ulnar nerve. A condition with the median nerve is the carpal tunnel syndrome. Know the ulnar nerve innervates those two exceptions in that flexor compartment, which includes the flexor carpi ulnaris, one half of the flexor digitorum profundus, and most of the hand muscles. So let's go to page 73 in your class notes, and let's go over these that we do have to know. Again, number one is the axillary nerve, innervates the deltoid and teres muscle. A weakness with this would be a condition that would indicate an injury to this could be weakness in shoulder abduction. Musculocutaneous nerve, know that it innervates the coracobrachialis, biceps brachii, and brachialis muscle. The radial nerve, know that it innervates all of these muscles in that posterior compartment of brachium and antebrachium. A condition associated with this would be wrist drop. Next on page 74, the median nerve. The median nerve, again, this is going to innervate all those forearm flexor muscles with the exception of the 1.5 that are innervated by the ulnar. A condition with this is associated with carpal tunnel syndrome. The ulnar nerve is going to give us that exception of those two muscles in the flexor compartment, which includes the flexor carpi ulnaris and the medial half of the flexor digitorum profundus, and most of the hand muscles. A condition associated with this is called claw hand. The long thoracic nerve, let's find that one, innervates that serratus anterior muscle. The condition with that is called the winging of the scapula. The suprascapular nerve innervates the supraspinatus and the infraspinatus. The thoracodorsal nerve innervates the latissimus dorsi. So make sure you review all of those nerves on page 73 and 74. Know what muscles it innervates, and also know any associated conditions, if any. All right, let's talk about the circulation in the upper limb now. The circulation, let's kind of go back to review here. Let's go here. Here's the arch of the aorta, right? Remember that? And off of the arch, we have the brachiocephalic trunk. On the left, we have the left common carotid and the left subclavian. Off of this, on the right side, off of the brachiocephalic trunk, we have the right common carotid and we have the right subclavian. We talked about how we call it a subclavian because it goes underneath the clavicle. So as soon as this subclavian artery travels in the axilla region, that name changes to the axillary artery. So in this region here, it's called the axillary artery. You can see it right here. Okay. So as soon as this axillary artery goes into the brachium region, we call it the brachial artery, it crosses below underneath the cubital fossa, and then it's going to divide into a radial artery laterally over the radius and a medial artery over the ulna called the ulnar artery. So this lower area is where we take the radial pulse. The radial pulse is located laterally. The ulnar artery is located medially. We can palpate the radial pulse if we palpate it with our combination of our index and middle finger over the radial artery. Normal rate is between 60 and 100 pulses per minute. Tachycardia is anything above 100 pulses per minute, and bradycardia would be below that. The veins, remember, travel in the opposite direction. The flow is in the opposite direction than the arteries. So the flow of blood is going in this way, where the arteries would be going in the opposite way. So the veins, the name of the veins travel, we separate these in deep veins and superficial veins. The deep veins travel with the arteries, so we have a radial artery and an ulnar artery, a radial vein and an ulnar vein that travel with the radial and ulnar arteries. And they're going to go into the brachial vein, into the subclavian vein, into the, this would be the brachiocephalic vein, and then into the superior vena cava. We have two superficial veins. The lateral one is called the cephalic, and the medial one is called the basilic. So the deep veins, again, you can see in this image, are the radial and the ulna, and then they're going to go into the brachial, axillary vein, and subclavian vein. Then the superficial, which will include the cephalic vein, which is lateral. This is going to go into the axillary vein, into the subclavian. The basilic is going to go into the brachial vein, and then axillary and subclavian. The veins, these superficial veins, are going to cross at the medial cubital vein that you can see right in here. And this is a common area for blood draws. It's in this medial, the anterior cubital fossa. You can see the medial cubital vein, often very superficially, and is easy to find if you're going to draw blood from it. Not always, but it kind of should stick out. The medial cubital vein serves as an anastomosis between the cephalic veins and the basilic vein. So the cephalic vein is going to empty into that axillary vein, and the basilic vein will empty into the brachial vein. Okay, so after the lecture, there will be a short quiz in the that I've posted for you, and I hope you get that done quickly.